Welcome to Getting Better with Dr. Adam. Dr. Adam Silberstein is a clinical psychologist who has been working in the field since 1993. With a broad range of clinical experience, including state psychiatric hospitals, adolescent residential treatment with a trauma focus, the Department of Corrections, and in the addiction treatment arena. Adam is currently in private practice and serves as a clinical consultant and supervisor for a number of treatment centers. This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there is an emergency, it is strongly recommended you seek treatment at your nearest emergency room.
I really thought it was important for me to have someone on the podcast to really help me bring to life what a day in the life of the care and treatment of our sickest COVID patients, right? What that's like from a provider's seat. And I had the privilege of having my younger brother, Dr. David Silberstein, come and speak on this podcast. It's actually kind of cool. It's one of his first days off in so long. He's been in the trenches. He's a frontline intensive care unit doctor, and it's not a funny conversation. And we're usually, for if you're listening, we sound alike. So I hope you could discern who's who, but you will just based on the content. And my brother brought to life, just what the atmosphere of treatment and care is, as an ICU doctor, both in terms of working with patients, with nursing staff, with family, the critical role of family, and what it's been like, and what his vision is in terms of how to be effective and effective in communication and sensitive and both in terms of offering sensitivity, but also clarity and good informed discussion and caring and compassionate discussion with family, and how to protect yourself as a provider from the just the volume of pressure and work, especially in this atmosphere of the pandemic. He said if being, one of the things he said is if being an ICU doctor, usually, on a bad night, the water goes up to his knees. It feels like it's always at his neck. And it's just been that way for him day in, day out. And the multiple challenges of navigating, critically ill patients, and how he does it with, to the best of his ability, with such a sincerity and a compassion and a genuine empathy. So I just thought it would be important for me, who's, kind of pandemic adjacent, in the sense that I speak to people who are stressed out and may have lost a loved one or maybe experiencing symptoms, but to be in the trenches with the people who are in the intensive care unit and so sick, and many who have passed away, just how challenging that is. And it really gave me a greater appreciation of what he does and what all the healthcare workers nationwide and globally are walking through on the front line. So I hope you can access that same appreciation I did. So blessed today. A special experience for me. I've never done this before in the second season of doing this podcast, and I have the privilege of speaking with my younger brother who is just a delight in so many ways, and is just a wealth of knowledge and experience. Dr. David Silberstein. Dr. David Silberstein is a board-certified internist. He is board-certified in sleep medicine, in pulmonary care, and in critical care, and he works in the ICU. And I say all that because it needs to I don't want to delve so much into that. And we could spend hours and hours and hours and hours, scratching the surface of his interests and his download that are so relevant and so connected to the work that I do as well. So many of his interests in spirituality and meditation and in mental health overall. And I could go on and on and on about him. But actually, that's not why I invited my brother here. And that could be for another time. I'm inviting my brother here and welcome. I'm inviting him because for the last many months since March of 2020, he's been on the front line in the hospital, working in the intensive care unit with COVID patients and their families. And it's just in watching you all these years and seeing you have a very hard job. You have a very, very hard job in so many ways. It requires such discipline and focus. And you deal with, what you're dealing, the heavy lifting that you do, the life and death situations are, I can't even imagine. But in watching you these past several months, it's just been something totally different. And I want to honor that experience and hear about it and hear about what it's been like. For me, I'm just to say to you, I'm here on the sidelines. All I got is the papers, right? I'm reading the papers. I'm living in Los Angeles. It's January 5th, 2021. And I know the data tells me, right, that this is a major hotspot and people are very sick and many people are dying. And my day goes on, right? Like I'm careful. I follow the recommendations of our government. I'm safe. I keep my distance. I wear my mask. Thank God I haven't suffered. I haven't gotten sick, and I'm just doing what I can. And I'm very blessed. It doesn't come alive to me, right? What you must be dealing with on a day-to-day basis. So with that, I thought I'd love to have you on to help me and others appreciate this experience you've had as an intensive care unit doctor. And also, just one more preface, I know I'm going on, is this is not, I want to be very respectful. I don't want to talk about where you work. I don't want to talk about individual patients. It's just a respectful inquiry about what it has been like for you on the front line. So with that, welcome, brother. Before we start, one more qualifier. We sound alike, right? We have a similar sense of humor. It would be hard for people to, if we're in a room and your eyes were closed, you may not know who's speaking. So I hope this isn't confusing, but the content will be very helpful. I can't speak his speak. So with that, welcome, Dr. David Silberstein, brother. How are you?
Thank you, brother. Yeah, we're both nasal. What am I going to say? But I think the importance of this will focus. First of all, what does it look like in the intensive care unit in general? Why would some patient be in an intensive care unit? And is COVID anything? Is it different? Is it special? And I think let's first start off by saying that the reason to be in an intensive care unit could be purely for monitoring reasons, for nursing care reasons. There are certain medications that can only be given in an intensive care unit. Sometimes people get operations and the surgical preference, they want hourly monitoring. On the regular floors, you can only monitor in certain ways, and the ICU tends to be a place where you can be monitored hourly or more frequently, minute by minute. The type of patient that I'm going to refer to is the patient who truly has critical care needs.
So there's something like an ICU chill, like ICU lower key, right?
There's something like, these are the patients where I tell them they're talking to me, they're being monitored, and in my head I'm thinking, this person doesn't need to be in my unit. And but that's okay. And tell them sometimes jokingly, I examine them, and then I tell them, the more you see of me, the worse it gets. I bless them with the blessing that I hope to not see them tonight. And if they need me, I'm always there for them. That's my sign off.
So is that the majority of your patients, or is that the minority?
It depends on what season and what era.
Okay.
So that's the thing. So we have a very robust surgical ICU. We have a very robust neurocritical care unit. We have a very robust medical intensive care unit. And the typical medical intensive care unit patient. Now, that being said, if we were a trauma, I don't work at a trauma center. If I did, the surgical critical care patients would probably be of that variety, but I work at a place where we repatriate trauma patients, but we do not. We're not a trauma center. The critically ill patients in my universe are typically patients who have medical conditions that require a ventilator or drips that keep their pressure normal, their blood pressure normal, or they have a variety of strokes and head bleeds. And so they can be critically ill, but they can be very critically ill in multi-organ failure. That being said, there is some, in the regular running pre-COVID, I would say up to 50% of our patient population are people who are there for monitoring only. And don't get me wrong, many of them get sick, but so what I would say about COVID, this is what COVID felt like. It felt like it felt like this. It felt like being on the beach, being in the water, having the water up to your mid calf, and then the next second the water's up to your chin.
Wow,
that's what it felt like.
So in layman's terms, while there could be like a high volume of chill, right? While that could be present, COVID took the chill and all of a sudden made it, and when we say chill, I want to be really clear. A day in the life pre-COVID of dealing with 50% or even 30% or 20% of people who are going to require such fragile, delicate care that at any moment, if they're not monitored, they could die, right?
Right.
That's your version of chill. And to me, like that would totally demolish me.
Well, even pre-COVID, my motto was always, it only takes one patient. It only takes one patient to, and if you hear background noise, I apologize. There is noise beyond my walls that I cannot control.
And by the way, for those listening, the noise, I want to celebrate it on this recording because this is the first time in so long you're on vacation, and this is the first time in so long you have breathing room, you're with your family, your wife and children, and you are so forgiven for the noise. I know it's hard to find a quiet place, but to me it's like, you deserve this time. You've been in the trenches for so long. This is one of your first times to breathe in so many days. So I welcome the noise.
Oh, well, thank you. And so one of the things that I like to talk about, it's not, it only takes one patient. That's what I used to tell when I was a resident, I used to tell my interns that. And anytime I speak to trainees, there is that one critically ill patient where, you can try to act like an aloof person. We can try to manage them from afar, but the best way to manage a patient who's heading in the wrong direction is pulling up a chair right near your bedside, or sometimes literally being next to the patient physically. And sometimes I have to physically be with the patient, put them on ventilators, put lines in them, do procedures. But ultimately, it's proximity to the patient, hands-on.
So, and for those of us who don't, we're all lay people here. I'm picturing tons of monitors, like monitoring medicines, levels of every kind, right? Breathing, breathing to, taking, looking at blood work all the time and, pulses, everything.
right, and tubes coming out of them, that type of scenario. I always say the more stuff you see around a patient, the more likely that patient is going to die. That's how awful that is. And so there's that. There's the patient, there's the patient's family, and there is the caregiver. And those are the nurses, the doctors, the respiratory therapists, and the rest. And all three of them need to be cared for. I would argue that in the world of medicine, the caregiver is the least thought of. And there's a mistake in the population of rich golfing doctors. I'm not saying doctors don't do well, but doctors and nurses shoulder a lot of, and doctors we're not pictures of mental health. And so I think, it's, having time to grieve losses is not something that we're trained about. We're not trained in any of that. Mm-hmm. And there's a large degree of physician burnout. I think physician burnout is a misnomer.
So dial it back for a second. We're pre-COVID. We're talking about a day in the life of an ICU doctor. Some patients require less intensive involvement, but some of, like you said, one very sick person could totally dictate a shift for an ICU doctor.
So can I give you a typical run of what
Sure.
it would look like? So you come in for your shift, you get signed in on your patients, and you get the list of incoming patients. And some of them are a batch of, some people are transfers from the outside from other hospitals into your hospital who need higher level of care. Some patients are coming in from recovery room. And then there are people who are on your watcher list, people who are sick and potentially who maybe will crash. I will call the rapid response nurses to see if they have any watcher patients on their lists. And then I just wait for my pager to go off. I'm using I feel like I'm a drug dealer in 1990, waiting for the pager to go off. And it starts going. And I start taking calls, and the calls themselves, I'm taking calls from patient in room X, in room 35 is crashing, so this is what you're dealing with. So it could be the one patient either in your intensive care unit on the floor. So I'm running to respond to people who are, I'm getting a call from somebody, this person is crashing, the emergency room. So the sickest patients in the emergency room come up to me. And from the outside, a patient who is deemed stable for transfer in comes in and they are crashing. So all of that can happen. And what would happen overnight is we'd have a mix. Unfortunately, sometimes getting a very stable patient, getting a call about a patient who doesn't sound like they need my ICU, but some doctor wants them in my unit, while I'm taking care of 3 patients at the same time who are critically ill in multi-organ failure, and I'm putting one patient on a ventilator. And then, all of this can happen pre-COVID. And I've had profoundly stressful nights where I'm trying to keep people alive and get them through pre-COVID.
And navigate the team of nurses and respiratory therapists, navigate the family, navigate the other doctors who are interested in seeing how they're doing. This is all pre-COVID, run-of-the-mill, day in the life of my brother.
What is the major difference? So one is volume. During a surge, as I said, it was like water up to your calf, and then now water up to your chin.
Uh-huh.
Within weeks, this exponential growth. And what's, in my unit, it's all of a sudden, we had a mix of patients, a variety of different types of patients. Now, every patient is the same patient.
Right. So there's no chill. Patient. There's no just the monitor types. This is all critical, super critical.
They're a minority of the patient population. Not only that, we've spilled into every other unit with a risk of running out of intensive care unit beds. With a risk, we ran out of, one night we ran out of, dialysis machines, continuous dialysis machines. That sort of brand. So our resources are stretched thin, personnel are stretched thin, and then this is the icing on the cake. Families have not been a part of patient care directly. we humans, there's a lot of nonverbal communication that goes on when some very scared looking family member is hiding in a corner when their loved one is not doing well. They can see it. Now, their understanding is based on a communication from a guy like me. And at my best, I'm a phenomenal communicator. At my worst, they don't understand a word that I'm saying.
Yeah. Yeah, you're not able to read the cues in the same way when it's live and in front of you because they're not there.
Absolutely not. And this is the absence of family has been a major difficulty because part of my job is treating the family.
Okay, let me just connect with this. So you're the team when somebody's needing critical stabilization in a critical moment, such a fragile time of life. You are sort of the liaison or team captain between family, between other providers, between the direct nursing staff, right? You're sort of managing it all. And that comes with a lot of stuff that isn't just knowledge of medicine, but actual knowledge of how to work with people and best practices of communication and, how to deal with crises and emotions flaring and sadness and grief. None of which you have a manual for, right?
None of which.
There's no specific playbook for any of this is what I'm hearing.
There are specialties that deal with this directly, but listen.
In game time?
No. It's sort of when the dust settles, we have, the palliative care physicians will have large family meetings. They're phenomenal. What they do, they are phenomenal at what they do. The palliative care physicians, they do a great job, and they work with us. But when game time, I love that, will be the time. It's midnight or 1 a.m. and the patient's crashing, and this is an octogenarian and an 80-year-old they're about 12 days out from their coronavirus onset. And they're in Florida. They're not only in respiratory failure, but they're in shock and their kidneys are failing. And no one in this person's life has had a discussion. I always say, again, it sounds harsh, but, a 90-year-old marathon runner is still a 90-year-old. And no one's had the discussion.
Right.
Family members are like, but my family member was doing so well. Because no one really gets the scenario. And now this patient, it comes to me. I've never met them before, and they come to me and they do not have the capacity to make decisions. And so now now guess what? Their daughter, their son, their sister, their brother, their husband is now a person, and typically a non-medical person, who now has to make and I'm going to clarify this as well. It's very important. I want people out there to know about this too. But they're going to help participate in the medical care of their loved one. And what I want from them is this: what was your loved one's? What is their minimally acceptable quality of life? That's a very important question. That's number one. What would, for example, maybe my minimally acceptable quality of life is going to be, I want to be awake. I want to be alert. I want to be communicative. I want to be able to interact with my family, and I do not want to be on a ventilator. Mm-hmm. I do not want to be machine dependent. Right? If I don't communicate that with my family members, then whatever, this is what happens. Children, I always say, we all get payback at the end of in the modern era, we get payback, with our kids because they feel guilt and shame for not doing enough, for not being enough. And the biggest gift that we can give our children is clarity when it comes to end of life. And it's very scary to think about. Mm-hmm. But I'm navigating those scenarios. And I want to be very clear. It's very important before you ask another question is people want to understand. Most people don't even understand what DNR means. DNR means do not resuscitate. It specifically refers to CPR, and intubation. And in fact, in our medical universe, we separate DNR and DNI. So I like to link DNR specifically refers to cardiopulmonary resuscitation. What that means is if CPR means that if my heart stops, and when my heart stops, that means that I die, right? Do I want to get revived? Do I want, after I die, do I want the medical team to try to bring me back to life? And that sounds wonderful. The typical scenario that the movies tell us is that, the guy's smoking a cigarette in Vegas. He's a 58-year-old or 60-year-old guy, obese. He's gambling. He has a cardiac arrest from a massive heart attack. All of a sudden, someone starts doing CPR. They shock him, and it's like the next second he wakes up and he's back to smoking a cigarette. It doesn't work like that in real life. Less than 5% of in-hospital cardiac arrests survive to discharge.
Mm-hmm. Wow.
in the country. I think our numbers are better, but the answer is it depends on the degree of it depends on how severe their underlying critical illness and their chronic diseases and their acute diseases are.
So nobody knows this information. The layperson, I'm speculating, doesn't have a sense of this information. You're in COVID times, you're inviting the family into these heavy-duty discussions that may or may not have ever been taken place. And there's nuances about what it means to save a life and what it means, what type of quality of life do you think your parent would want or your loved one would want. And all of a sudden, it's just all so heavy and there's not a lot of time in game time. There's not a lot of space to have. There's not a lot of room for deliberate time mediated over days. It doesn't work that way. It's not. It's a little hard. It's hurry up offense.
Yes, but there's more in that. So one, the family's not there. So they already feel an extra burden and they feel guilt that they're not present. What is something they can be doing? It would be helpful, that sort of guilt. The second thing is they don't understand what DNR is. So what I'm going to say, it is a clinical decision. Sorry to, if people don't agree with me, but the idea of CPR or not CPR is, yes, there is a patient decision, and I'll explain that. If it was designed to protect patients from us who did not want to be resuscitated. So when we graduate from medical school and become doctors, we now are physicians. I just laugh at the seriousness of it, but the truth is we take this oath, the Hippocratic oath, to do no harm and alleviate suffering. But the truth is, and this is the spiel I give patients and families, I will often go right into this because I want people to understand this. We do things that cause suffering all the time towards people. We do operations. We cut people. We set bones. We intubate patients. We do all sorts of procedures. But the implicit understanding is if we can cure disease, that by definition is an alleviation of suffering.
Even if you have pain on the front end.
Yes, and then there's the second level of patient where we know. Listen, we live in a time where we just take chronic diseases for granted. But we have diabetes, we have hypertension; those are chronic diseases, and we have other diseases where I come into the hospital. I got an overwhelming infection called sepsis. I got shot, and now my kidneys are knocked out, and they're not coming back. But I'm stabilized. So now I have a chronic illness. I'm not better than when I came into the hospital, but we say, okay, it's still alleviation of suffering if we can get you to a new baseline. And we cause you suffering on the way, on the front end. And then there are times when we can neither cure nor stabilize. And so that's one. And in those situations where we can neither cure nor stabilize, CPR becomes a clinical decision, meaning not a family decision. Our family discussions are really to get patients' families on the same page as us. right? Because no family member could tell a surgeon, hey, I want you to take my father's appendix out. That would be an inappropriate, that would be a very inappropriate thing to say, because the surgeon would say, well, he doesn't need his appendix out.
Right.
Right. So that's one form of DNR, which is cannot cure. The term we use in medical ethics is non-beneficial care. The old term was futile care, and that's not seen, it's not kind. So we say non-beneficial care. We are not obligated as physicians to provide non-beneficial care. Now, don't get me wrong, there's a lot of ethical gray around that. But when we have these discussions with family members, it's really the other way. When a family member does not, when let's say I as a person say, I don't want CPR, it's to protect against us. And because the way I say it is the way I say it and the way I see it is that if I do anything to you that you don't want, it goes from being a medical procedure to being assault and battery. And there's legal precedent for this. These are all cases, I think, that they come out of California. So initially in the 70s.
So protecting against you means you just don't. Part of this discussion is helping guide you about how you're going to treat or not treat an individual. Yes. And these are all critical discussions. And I want to just picture what's going on. Pre-COVID, when the water's up to your knees, right, you can gather yourself for these insanely, right, heavy, loaded conversations that are life and death, that have grief and loss all over the place, and pain and history and all this luggage and layers, right? You have the bandwidth to deal with it on a hard night when the water's going up to your knee, and your personnel you're fully staffed. And even then, it's super hard, and you're not exactly trained in the best forms of communication and empathy and all these things. Come COVID, where the water's up to your neck, and it sounds like you've been working, right? That the medic, not nationwide, right? Our doctors are in the trenches, right? Working well beyond some people, 80, 100 hours a week, right? With little time off, not because it's the preferred method, but because what else are we going to do, right? It's crisis time. And you have, if your ICU is X number of beds, right? You're having this conversation multiple times a night.
Right. Well, our ICU,
or a shift.
And we're over capacity, meaning our ICU historically in our hospital, we have multiple different intensive care units for different specialties, but we're taking over all the other specialty units with COVID patients, and this is again multiplied by many hospitals within my healthcare system and outside of my healthcare system.
Nationwide. This is happening. So I'm trying to picture myself a day in the life of you. I have to make room to have in a given night. How many of these conversations could you have in COVID season?
I'll be honest, the last night I was on very little because it was just nonstop. Just to give you a sense of it, it was like intubation lines, intubation procedure, code. And one of the patients that we had, we didn't have an ICU bed for them. And they were critically ill. I had to sit with them on a floor bed with a critical care nurse and do everything that I would to manage this patient, but I couldn't really leave the bedside. Shocked them. They got 5 shocks.
So sometimes you're so busy, you're so swamped in COVID, you can't even begin to have these challenging, painful discussions, right? And you mentioned earlier, like this idea of the doctor, making bank and playing golf and
right.
And
it's total misconception. It's so that misconception of, where, there are physicians that may work like that in certain fields, but with what I do, we're bedside, we're in the trenches.
You're in the trenches, but so sometimes you have to deal with the imminent emergencies, and you have to be coding, and you're in the middle of a code and what that means. Sometimes you're talking to family. Meanwhile, right, people are dying I'd imagine, around you all the time. And you, in a given night, may not even have a minute to digest that, because you have a whole slew of people who are dying.
Yeah. And so the 22-year-old, you know, I know it's going to sound hard, but like, for example, a 22-year-old or the 47-year-old, or, the 47-year-old with 3 kids, is going to hit me at some point.
Yeah.
And it's going to hit all of us. And I think the inability to process that is a profound loss. The inability to, no one, but again, I think, I'm not going to say poor me, I'm not the one in the bed. But that's part of it. So it's the like sort of the trinity, the patient, the family, and the caregivers. And care for the caregivers, I'm going to say it, we're not thinking about that, the moment we're dealing with crisis, but that is still important.
So I want to take a step back, and I said I wouldn't brag about your resume, and I'm not going to talk about your decorated medical life, right? But what I am going to talk about is you're known as a very good communicator and a very, very, very kind and empathic person. And I would venture to say, and some of this is biased because you're my brother, but some of this is because I know you and I know your reputation, that you're the gold standard of bedside manner and how to deal with people. And how does someone like you, who's so seasoned in skillful, kind, honest, direct, and compassionate communication, what happens when you're spread so thin like this? What was it like for you?
So sometimes, I'm thinking about a few different just anecdotes. So one recent patient I called, actually, I'll think about 2. I called, so we can get family in. Later in the pandemic, there are ways to get family in to the hospital. And I just would sit down with them in a room, masked up, and unless there was something that I had to attend to right now, I would sit and I would have that conversation, even if it meant that something else was was a minute that I wasn't able to put my feet up, and that's hard. But sometimes that conversation just has to be had, and it's a very hard conversation. The other one was a patient who did survive, but he'd had a long, drawn out. He was COVID. He'd been in the hospital so long, he was no longer COVID positive.
Wow.
And I thought he was about to die. And it was me and his kids and his wife. And the kids were older, but the youngest was in high school. And just having the conversation, explaining, asking, do you have any questions? And there was an hour-long conversation in a night where there was another, right before that, I was delayed. I made this poor family sit there waiting for me because some other patient was crashing and I had to help out. And, and then I spoke, and it was an hour-long conversation. And I wouldn't some people would say, well, Silberstein, you're being inefficient.
Yeah.
But these are people, it's much more efficient when family members, are in the ICU. So it used to be that floor beds had visiting hours. The ICU, there was the policy pre-COVID was that there was a patient family member inside the room at all times. That was, you're critically ill enough, you could have a family member there at least, sleeping there.
And that helps you so much as the provider.
Oh my God. It's not even a question, that nonverbal communication.
So
now what we get, and I want to say the other side of it is now family members, there are different attitudes that people come to the medical world with. And this has been studied widely in sociology, where some people come to the medical world with trust, and some people come with massive amounts of mistrust. Some of it which has historical precedent, right? Some of which, is just people are suspicious. Some of it may be a medical knowledge issue.
Some is cultural.
Some of it could be. Some of it could just be that they had some bad experience. And these people are, these are poor people who are mourning, or they're coming to terms with this massive event. And I'm just, and on a bad night, I'm not bringing my compassion. What I'm doing is like, listen, I got to have this family discussion, and then I got to move on to the next thing.
Right. And in COVID times, how many of, you can just be walking through a sea of people passing away, right? Like that, it's on a given night, it could just be one after another.
I mean, look, we're going to, hopefully by that time, again, people are in varying degree of family discussions. And so when it's well oiled, so this is what I would say, the larger team approach. This is what in my hospital, we round multiple times a day. We're 24/7. So family discussions happen at all hours. And the rule is every day, every family has to be communicated with. You hope that they are communicated with well. The palliative care doctors and team have been helping us with rounding out the communication. I think the specialty palliative care medicine is invaluable in helping their team, at least in our hospital, a team involves a physician, a nurse, a social worker, clergy, all trying to get at what the patient's life was like. We have social workers who are rounding out the story. For example, this woman, this poor lady, my first call to a family member after I put her on the ventilator was her son. And then her son stopped being reachable. And then her son died of COVID.
Wow.
Her father had died of COVID. And she survived. I don't know. She was long out of our ICU. Someone must have told her at some point.
Yeah. And
so that type of tragedy abounds. But again, yes, on a given night, on a given 24-hour period, there could be, let's say, on a bad day. Again, I don't want you to think of it as every patient dying all the time. We'd have ICU capacity, but at its worst, even in our hospital, we had one day where there were 10 deaths. That's a lot for her. That's a lot.
And in a given day.
That's a lot in a given day.
Yeah. I want to just round out this discussion and just think about, you've given me a lot to think about in terms of what would be the gold standard of, what could physician providers use? What could the nursing staff use? The respiratory therapists, the system in general, right? It just sounds so overloaded right now. But if you had to create sort of the gold standard of best practices, given all that you've seen, right? And now that you have an experience of such a surge of nonstop critical care patients. Now, if anything you've learned, what would you want to change, and what would you want to impart to families, to providers, to the public? What would you say would improve, or how would you approach this if it ever happened again in your career?
I think that the realistic version of this, or the wish list. The wish list would be, I would love to have a healthcare system that were robust enough to deal with surge. But that is very often very expensive, and I don't know I'm not sure about the reality of that situation. Because again, we have a nationwide nursing shortage. But I would say, in a time, I consider this almost like a medical time of war. There needs to be a lot of compassion and forgiveness on all sides. That's number one.
What is that? What do you mean by that?
Meaning, as hard as it is it's hard for us, it's hard for family members. So everyone's got to, I think in general, even if this were to happen again, I think we're actually doing a fairly good job considering. At least to where I am, we're doing a phenomenal job given the set of circumstances we have. If I could really reallocate resources if I were the sort of the authority figure, I would create a healthcare system that would enable a rapid reallocation of resources to the highest degree of need. So if that meant a mass casualty, and I'm not a trauma doctor, well, guess what? You are today, that sort of thing. And that would allow people to, you need to double the amount of resources that are dedicated to communicating with family members. So if I really were, I would implement medical technology at the highest order, manpower at the highest order, to first and foremost communicate with family members in a way that is more robust than we are currently able to do. But that, again, so what that means, that means that you need somebody who's knowledgeable. A nurse will often feel uncomfortable giving the medical plan of care to family members. In fact, a doctor who's covering. So, what if we just said, "Hey, there's a physician who's not doing anything right now in COVID. Why don't we just make them talk to family?" Mm-hmm. Well, you have to have a certain degree of literacy. So the other thing is that I think it's very important. I didn't get a very heavy-duty degree of training in my ability to communicate with families. The way I learned was from people, apprenticeship. That's what residency is. I think that a curriculum and practice dedicated to, I think young physicians working with palliative care physicians, working with critical care physicians, and really including the medical students and the younger physicians who are in training on how to have discussions with families would be very important. Implementing extenders. So I'm not just talking about nurse practitioners and physician's assistants. I'm talking about, getting, we need more social workers in the hospital, even clergy. I think that the people who can actually have a human touch in speaking with, family members, you don't realize how many mental health providers are probably needed. Again, this is my wish list.
Your wish list. What about the wish list for you and the nursing staff and the ancillary staff? Sort of on the front lines. What do you think? And you mentioned several times that there's a lack of training, a fundamental expectation to communicate, and people may not have the skills. But also, kind of, what do you do? Meaning, I'm thinking to myself, oh my gosh, how much PTSD is there going to be? What do you do to support the pain of the right?
So, I think right now we're it's at an infancy. So there are some physicians who are prominent in sort of the YouTube universe that don't want to call it physician burnout. They call it moral injury, because really a lot of it is that type. But really, what this is, some of it is it's a combination of maladaptive behavior where our response to this degree of pain, suffering, stress is going to be to gravitate towards something that will disconnect us from our feelings, whether that be an addictive type of response, or I really get into legalize gambling on the stock market, or workaholism. I mean, physician burnout. Another term for it would be we see dollar signs and they'll distract. Again, just from work shifts. We see, I can work 100 hours a week. There's no body. There's no physician legislative body or nursing legislative body that says, is that really healthy? Why not? Because there's a need. Hey, you want to work? You think you can work 80, 60 to 100 hours a week? Go right ahead. Mm-hmm. And I think that is a shame because yes, there are people who are more resilient than others. The other thing is I see the really nice attempts by organizations to create physician resilience or caregiver resilience, but really there's no substitute for sleep and unstructured time. And if I could, I would force everybody, if you work 60 hours a week, You need to, for every 1 day of intensive care unit work you do, you probably need to have that much time off.
Right.
And
For if we're talking about the mental health of the providers,
yes.
and the burden that they carry, the pain that they're holding. What was the word you used? It's not burnout. It's, what was the term?
Some people say moral injury.
Moral injury. I don't know if I
don't know if I
love that one. I don't know if I'm not. Maybe I'm not understanding it. But
I don't. Because I come from a different perspective.
What's the moral injury, Dave?
Moral injury is really pointing the finger that it's it's basically like, this is the corporate structure with corporate incentives that lead to harm. And I come from a very different perspective, which is, yes, that, there is that. But I was the one, I didn't find myself in this situation. I signed myself up for this situation.
Yeah, I mean, I can, whatever. That's, to me, I'm thinking about what happens when I have to, I watch the 47-year-old man with 3 kids die in front of me, and I have to hold that, and what, taking away all the financial issues, and I have to then tend to another family, and I just sort of have to compartmentalize that, and then I have to work another 80 hours, and
right.
Well, how do I take care of the nurses and the doctors, and what kind of support would they need? Right. And you're saying, well, they can turn to drugs, they can turn to alcohol, they can turn to gambling.
Right. What happens when all of a sudden I begin to dread what I'm doing, rather than love what I'm doing? That's a very scary sign. And what happens when, and I love what I do, and what I need to do to take care of myself. So here, what do I need to do? I need to get adequate rest. And I am responsible for protecting that, regardless of what corporate incentive there is. And this is really important. I need to make sure that I don't use workaholism as, and this is, again, I'm speaking for myself, because I think that there is no national structure. There's not the research is there, but again, focuses on resilience, on mindfulness meditation, on exercise, but it's a whole package. So I am responsible for making sure that I don't work too much. I need to get adequate rest. I need to get unstructured time. I need to spend time with my family. I need to have a meditation practice and a spiritual life, however you define it for yourself. Things that give you that recharge of the battery. So you can come in, and some of that recharge is going to be feeling the grieving process. You're going to have. It's just inevitable. I had a therapist that once told me, he's like, guys like you, it's either the bottle or suicide, unless you do something positive for yourself from a mental health perspective. So, and I really think that it's really important. Taking care of my mental health, and I think nurses and physicians who do what I do really need to focus on their mental health, so we can be really available and really present for patients and their family members.
So close with this idea, right? Give me a parting thought, right? So let's say you're speaking to a group of therapists in training and seasoned psychologists and psychiatrists, the mental health universe, right? And you're trying to give a message of how we could support frontline ICU staff personnel, right? What do you tell us? How can we support you?
I think that the devil is in the details, and that I think you really suss out the details of why this person, really just pick it apart. What are the maladaptive behaviors that this person is buying into, and the beliefs that this person is buying into. Some of it is I'm a lesser doctor if I'm not working 100 hours a week. But look at the maladaptive behaviors and the really faulty belief structures that people are really buying into, the stories that people are buying into.
What it means to be a good doctor in general, in terms of care, in terms of loss, in terms of what it means to be, what your version of team means, and do you know how to say no sometimes? right?
Say no, and also, and maybe you're trying to control too much. Maybe you think that you have more control than you have, and also recognize that sometimes, that in order for you, sometimes you do have to step up to the plate where other people aren't going to. Sometimes I did have to stay, 6 hours extra without pay to get somebody on heart-lung bypass and save their life.
Right.
Like sometimes that had to happen.
So mental health can be the details of beliefs and knowing when to push the accelerator and knowing when to put your foot on the brake, knowing someone's values and core beliefs about what it means to be a healer in general,
Yes.
could be a good start. Well, I can go on with this for a long time, and I really just want to say, even though I'm working and I'm dealing with the so many people, in my practice who are, whether it's adults who are just so stressed out and scared, or children who their whole universe has been dramatically changed. I just want to tell you, I so appreciate, I have a much greater appreciation of a day in the life of the space you're in. I'm so happy you're on vacation, in light of our last few minutes. I'm just so happy you're on vacation.
Me too.
And I hope that our culture is so good at like rapidly shifting focus, and for a minute there, America's heroes, and then you could become the villains and the greedy, right, and the unfair, and you could become a lot of things in any given moment. But I don't want our world to lose sight of the fact that somebody like you, who I'm close with, has been not, and you're invested in self-care and doing protecting your mental health, but these last many months you didn't have the luxury of doing that, and have just been in this storm. And I just want to know, my heart reaches out to you, and
Thanks.
And I so appreciate you talking with me.
Oh, I'm so appreciative of you giving me time. It was really helpful for me just to talk about this in this way. And I would say that when we work at our best, the small things, like the ability to have capacity to feel when somebody who is awakened with it. Now, we're not talking about family. We're talking about a patient herself. I told her that she needed to go on a ventilator. She was huffing and puffing, and I had to have an interpreter there. That's a whole other level of difficulty when I'm using another person who's interpreting for me. And she started sobbing, and because I was not yet burnt out that night, I was able to have capacity for her profoundly emotional response.
Wow.
She started wailing.
Wow.
And just the ability to hold her hand, do what I got to do, but also feel it. That's really where it is. It's our ability to take it in and feel it and let it out in a healthy way, so we can be human beings. And again, I really appreciate your appreciation for what we do. And again,
Dave, if we ever do this again, me and, just for the audience, we're way funnier than this very unfunny conversation. This is really, really unfunny, but there's a love and a lightness that we have that's really never this. And, most of it is play, but it hasn't been that way lately for you. And I understand why. And I just want you to have a good time. And this is the next time you come and speak for me on this, I would love it to be about expertise and a little bit more academic. This was just very helpful for me right now. So thank you so much. Enjoy your family. And
thank you, brother.
And we'll connect soon. And I won't leave your information. You're the last person who needs to be contacted. Usually I say, if you want to reach him, I'll give out an email and a number. I don't want that for you. So have a good time.
Thank you, brother. Have a wonderful evening.
Bye.
Bye.
This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there's an emergency, it is strongly recommended you seek treatment at your nearest emergency room.